everyone. I'm Sanchika. I am from ECHO. A very warm welcome to all of you in this webinar series. Today is the topic number 11, that is the Quitline in Rajasthan. We have joined with us our chief guest, Maj.General Dr. Prof.Atul Kotwal ji, and our subject matter expert is Dr. Rakesh Gupta, President of Rajasthan Cancer Foundation. Very warm welcome to all of you. Now I would request Mr. Arun Vama, who is the Director of Finance and Operations from Sipher, for the welcome address.
Yeah, thank you, Dr. Sanchika. Good evening to everyone. Yeah, it is my profound privilege to welcome our chief guest on two count Maj.General Dr. Professor Atul Kotwal, who is an Executive Director, National Health System Resource Center, Ministry of Health and Family Welfare, Govt of India. I have to welcome him on two count. He is our chief guest for the today's webinar, as well as he is a decorated Major General from the most decorated services of the country. I also welcome Dr. Rakesh Gupta, the President, Rajasthan Cancer Foundation, Jaipur. He is a tobacco cessation expert. We are highly obliged to Dr. Rakesh Gupta. He is always available to us as and when we request him, even by bypassing his own urgent assignments. Thank you, Dr. Rakesh Gupta, for being so cooperative and being so obliging to us, especially to the Sipher. I welcome Dr. Rakesh Gupta, President, Sipher. We are also expecting Dr. Sonu Goel, who is a Director, Resource Center Tobacco Control, as well as he is a professor from the Department of Community Medicine, School of Public Health, PJMR. He is expected to join soon. Maybe he is busy with one of his projects. I also welcome Dr. Sanchika Gupta, Manager Projects, ECHO India. Also welcome Mr. Rajiv Chaudhary, who is a program coordinator for Resource Center Tobacco Control, PJMR, Chandigarh. Our eminent participants and public health students. I would like to share with you that the Strategic Institute of Public Health Education and Research, known as Sipher, was established in 2018 with fundamental purpose of creating a specialized public health workforce that can plan, execute, and monitor national health program and public health initiatives for tackling emerging public health challenges. We are working on all public health issues with a special focus on the non-communicable diseases. In the last about 5 years, we have organized more than 100 physical as well as virtual workshops and consultations. We are working in collaboration with the Resource Center for Tobacco Control, a joint initiative of PJMR Chandigarh and the Union, which is emerging as one of the most sought after platforms that showcases tobacco control initiatives, updates policies, resource material, etc. from the length and breadth of the country. It has helped in strengthening the national control tobacco program to a large extent. So once again, I welcome each and everyone, especially our chief guest and the resource person, Dr. Rakesh Gupta. Over to Dr. Sanchika.
Thank you, sir. Now I would request Dr. Rakesh for discussion on the objectives of the webinar.
Dr. Sanchika, can you please check if Dr. Sonu has joined? No.
Yes,
okay,
yes,
he's there.
Yes, sir has joined. Yes, sir has joined. Okay.
Okay.
Yeah, thank you, Dr. Rakesh. First of all, I would like to thank Professor Atul Kotwal for being the chief guest of this occasion. I know that he's extremely busy, and I was talking to Dr. Madan Gopal today that tomorrow is one. I think on 12th next week, early next week, you are having a major event nationally. So I know that how occupied you are. So thank you, sir, for coming here. Next, I would like to appreciate the effort of Dr. Rakesh Gupta from both Dr. Rakesh Gupta, one from Rajasthan Cancer Foundation, President of Rajasthan Cancer Foundation, primarily an oncologist, but then turned a public health physician, and he is much more active than I am, and many more youngster than so he has been doing this tobacco cessation for last many years now. So I think it is more than 20-25 years he has been practicing tobacco cessation. So that will be, I think, a treat to listen to him today about how tobacco cessation can be scaled up in the country and what are the efforts which has been doing, which Dr. Rakesh Gupta has been doing as President Rajasthan Council Foundation for tobacco cessation in the country. So welcome, sir. Welcome for this webinar. And second, compliments to Dr. Rakesh Gupta, Sipher, Arunji, and the entire team for, I think, sustaining this best practices webinars for last many weeks now. So I have seen that in almost in every week, we have an excellent speaker and also a chair of eminence. So last time I was there, so then Director Ames Patna was there. So similarly, I think you have called many alumnus speaker as well as chair for the session, and I can see the audience. So audience is always like they are always eager to listen to such webinars which has been hosted by you and your team. So congratulations for Sipher for excellently hosting these sort of webinar. So the current webinar is about is a part of some good practices or best practices under National Tobacco Control Program in India. And in this program, we are normally taking one good practices every week. So this time, the good practice which has been talked about, which will be talked about, is the Quitline in Rajasthan. So tobacco, there is a national tobacco Quitline, but there is a state level Quitline in state of Rajasthan. So Dr. Rakesh Gupta, President, who has conceptualized this Quitline, will be talking about what are the benefit of this Quitline and how what challenges he faced during launch and after launch of that Quitline. So without taking much of the time, I think I'll give this mic to Dr. Rakesh Gupta. And one more thing I want to appreciate is Eco India. So Sanchita is always there in Eco India, who has been there for all these webinars. And it's a seamless type of portal which I have seen, very user-friendly portal. So I must compliment Eco India as well for supporting us in these webinars. So
Thank
back
you,
to Sanchita. Yeah.
Now I would request Dr. Rakesh from Sipher to introduce our guest, our chief guest for the day.
So I am delighted to introduce Major General Professor Dr. Atul Kotwal. So as already told that he is a Seva Medal, Wishes Seva Medal, and he has done MD in PSN and many other degrees, FRCP, FAMs. And presently he is Executive Director of the National Health System Resource Center, Ministry of Health and Family Welfare, Govt of India. His experience is more than 37 years, and his areas of expertise, they include health systems, planning and implementation of the healthcare policies, primary healthcare, urban health, epidemiology, implementation of the research, and interdisciplinary research. So vast experience of working as a public health specialist and epidemiologist. So there, he has got significant contribution to the field of public health, epidemiology, administration, research, teaching, mentoring, planning, and finalizing the 11 5-year plans. 11 5-year plan. Yeah, comprehensive primary healthcare, quality initiatives in the public healthcare institutions, reviewing NRHM and conceptualizing urban health in addition to WASH and WCD related activities as OSD-Public Health and Planning Commission. And he has been amply awarded, like I already told you that he has got Sena Medal, British Seva Medal by President of India, Operation IPHA. And currently, as I already told you, that he is working as ED, NHSRC. So his research projects and academic work are many, published research articles in more than 150 peer-reviewed journals, NHSRC projects Health and Wellness Center assessment in 18 states, review of the public-private partnerships in healthcare under the National Health Mission in India, and he has done evaluation of Kilkari and Mobile Academy project, evaluation of the MCTFC, comparative assessment of various models of mobile medical units, and he has also assessed out-of-pocket expenditure on medicine, evaluation of the Dhan Mantri Ujjwala Yojana, and evaluation of the mainstreaming Ayush. So you're welcome, sir, and we'd like to have opening remarks regarding this topic of these toll-free helplines regarding tobacco cessation.
Thank you, Dr. Rakesh, and I must thank the organizers, Sipher, Strategic Institute of Public Health Education and Research, ECO India, and of course Dr. Sonu Goyal, so for inviting me. Given it's a matter of honor and pleasure to be here, because in public health, as we all know, that we look forward to be part of any event and any the organization and people who are working for the betterment of the health of the people of the country, and of course anywhere in the world, of course, definitely. So it's a tobacco again is one of the very most important issues right now, as we know the increasing number of non-communicable diseases. I think all participants through this webinar are aware the burden of the mortality, and 63-64% is due to the non-communicable diseases. And a large reason for that could be ascribed to the tobacco consumption, smoking as well as smokeless. And smokeless, I think, somehow is increasing more and more as we put more and more the restrictions on the smoking tobacco, about the smoking places, and also the warnings on these on the labels and all. So India has actually got an admirable status, because there are a large number of the various components of the tobacco cessation program, which we are trying to implement since last several years, and the quality delivery rate and all also of these services. And I'm not going into details of what all the program entails, what is FCTC and all, because that is everyone is aware. But I must come to the innovations now, that this talk on Quitlines, which has a good, excellent, the success rate, and the innovations and best practices. These are the two things which can address a large number of implementation challenges in our country. And implementation is always a challenge in our vast country. There have been a lot of the best practices as such in tobacco control also, where we included the public health associations, the social marketing interventions of tobacco control, tobacco industry interference as such, how that has been addressed in various methods. E-cigarette and the tobacco, the platforms have been created, tobacco-free educational institutions and all, and formation of committees. Even in Rajasthan, there's a smoke-free Jhunjhunu district, which is the first district, I think, over there. Tobacco-free Char Dham Yatra is another initiative by Uttarakhand state. There's a rose campaign in Mangalore and Kolar districts and all also. And so we need to now, with the tobacco end game as such, look at various innovations and best practices, how we can replicate them, how we can upscale them. So I would be listening to Dr. Rakesh Gupta, who is again a doyen in this field, to share the Quitlines initiative, how it is helping, and how we can all learn from that, and think that how we can it's time now to replicate the successful initiative and upscale it in various parts of the country. I think with that I will stop here. And once again, thanks to the organizers for giving me this opportunity, and looking forward to an enlightening presentation and interactive discussion from everyone. Thank you.
Thank you,
So
sir.
thanks a lot, sir. And in very few words, you have summarized the tobacco control problem and why the tobacco cessation is important. So over to Dr. Sanchika, please.
Now I'd like to introduce our guest speaker for the day. That is Dr. Rakesh Gupta, who is the president of the Rajasthan Cancer Foundation, who is a surgical oncologist and a WHO awardee is President Rajasthan Cancer Foundation and an honorary consultant in tobacco cessation. Also, he's an expert. He's on expert committee of Ministry of Health and Family Welfare and core committee of NOHP for advancing tobacco cessation countrywide. His pioneering maiden work in India includes smoke-free district, city, tobacco-free workplaces, systems approach in tobacco cessation delivery, Quitlines in India, and engagement of state medical helplines to deliver tobacco cessation. He has authored 2 books as well, including Tambaku Mukti Ki Or and Tambaku Niyantran Ke Mudde. So very warm welcome to you, sir. Over to you, sir. You are given screen sharing rights.
Yeah, thank you. So my thanks to, just a minute. Let me begin by thanking my friends, Dr. Rakesh Gupta and Dr. Sonu Goel and Arunji, who have always been very highly appreciative. And I think when you appreciate, it also raises the expectations of the participants. So I would like to lower that down a little. I am grateful to the organizers, Sipher, RCTC, and ECO India, and also the inclusion of this case study in the GRIP Volume 1 for making it more available to the people across the country. I am definitely conscious of the chief guest, who is a highly decorated, esteemed armed person and armed forces person, and also because of his vast experience in the public health. And also it's a dream come true because he is in the right place where the state medical helplines can be utilized, I would say utilized by the national Quitline services to strengthen their human resource and infrastructure, which is currently considered a little short of the expectations and list of those who have registered to quit. So from that angle also, I feel I'm much obliged, and I feel this is a great opportunity to advocate for going ahead with the replication of this study in the other states of the country. And to you all the participants, I am grateful because of your kind presence and the time that you are going to give us. My agenda is broadly in 2 categories. If I had to say, it's general information on Quitlines, because many may still not be knowing everything about the Quitlines, with which I have been associated right from the time Quitlines started in India. And then I will talk about the case study, giving its background, then giving a brief on its operational aspects, what challenges it has been having and it has had in the past as well. And also then I'll talk about the results and the lessons learned through the experience, which has now extended to close to 10 years. And then I'll also talk about its institutionalization and the translatory value, and conclude with a few recommendations. So what is a Quitline? If I had to tell in layperson's language, it's a telephonic counseling service to assess and assist a tobacco user to quit tobacco. Now, I was introduced to this way back in 2008 when I was working with the American Cancer Society as a director for India for the Indian Workplace Initiatives. And there I knew that there are 2 types of Quitlines. One are reactive Quitlines, which respond to the need of the person. That means a person calls for helping to quit telephonically, and then the counselor responds to it. The proactive Quitlines, which are more used and are more frequently available now across the world, I think are those Quitlines where you register for quitting tobacco, any type of tobacco, and then the counselor gives the initial session and then proactively follows it up for a period of 6 months to 1 year. So that is proactive Quitline. I was recently reviewing the Cochrane Library review of 2021 or 2019. Yes, it was 2019, where I found that out of the Quitline studies which have been published until 2019, out of 104 or 105 studies, over 100 studies are primarily on the proactive quitlines. I am giving this figure to say that how popular and useful proactive quitlines are, and also it's a matter of preference as to which quitlines should be made available to the people. Now, what are the advantages of Quitline? There are 4 significant advantages. One can access the facility for quitting tobacco from anywhere and anytime as per the work hours of the Quitline. Second is the confidentiality of the caller, which is related to third, that here it spares tobacco users a visit to a tobacco cessation clinic to our hospital. So you're just talking on telephone without giving your identity. If you don't want to give, even Quitlines don't take your identity. And lastly, Quitlines have a distinct advantage that it also provides a database for a ready assessment as well as for research, because it records all the calls, the features of the tobacco user, and also the contact number, plus the outcomes as well as the challenges and barriers the users have when they are undergoing the process of quitting tobacco. A brief about the history and contributions of Quitlines. Quitlines were first established in 1988 in United Kingdom. In United States of America, these came in 1992. 3 things these have been able to do. One, these have improved the access of the users to quit tobacco. Secondly, these have established and shared the norms for providing the quality of the service delivery, which I think is very important, because as we are expanding our horizon of tobacco cessation, this is one need that we'll have to see and ensure, because people should be able to provide the cessation delivery with quality. And lastly, we need these define and measure the efficacy of the services delivered. The mechanism is, of course, the self-reporting by the users, but I think that's pretty reliable. We have the evidence that self-reporting is very reliable method used by most of the Quitlines, and as compared to the biochemical confirmation, the quit rates are 10% lower than the quit rates that you get after the biochemical confirmation. So my reliance is mostly on the self-reporting. Now, there are world over 3 regional Quitline consortiums. One is North American Quitline Consortium, which includes North America and Canada. The European network of Quitlines, predominated by the Quitlines present in United Kingdom. And third is Asia Pacific Quitline Network, which also includes India and Thailand, besides the Western Pacific region countries which are there. So Asia Pacific Quitline Network was established in 2008. I have been its participant to represent India, informally, of course, since 2012, after having participated in the World Conference on Tobacco or Health in Singapore. And besides India and Thailand, it has all the countries, as I said, who are working with WHO Wipro. In addition to WHO Geneva, the mentors have been from the Quitlines working in USA, Australia, and UK. And let me share that it was a privilege to have the mentors from these the prestigious Quitlines who have given a lot to the field of tobacco cessation delivery to the Quitlines world over. We are actually very proud to have India as one of the 26 member countries of the WHO FCTC that have a status of comprehensive cessation delivery as of 2021. When we say comprehensive cessation delivery, it includes 3 features: availability of tobacco cessation clinics. We have the TCC now in virtually all the districts of the country working under NTCP, which provide counseling and also the nicotine replacement therapy as the essential medication. Then we have a national Quitline. Most of the people know that it has a toll-free number 1-800-11-2356. And then we have a telephonic messaging service, again operated by the Ministry of Health, which is M Cessation. The number is 011-22-901-701. Both these services have a significant quit rate. I think the quit rate for national Quitline, if I recall correctly, through one of the published reports, it was 38% at the end of 1 year. And through M-cessation, it is about 20%. So these are pretty good services to be utilized if you cannot access the tobacco cessation clinic close to you. What is the cost of cessation for an individual through a Quitline? This paper was published by our National Quitline Service through Dr. Rajkumar and Dr. Saroj. And it says that counseling a user costs these Quitlines 1,843 rupees and counseling a quitter costs about 5,765. Considering how much a person uses on tobacco if he doesn't quit, and even in a year, I think these costs are pretty less as compared to what a person will keep spending through the tobacco use and also eventually for the management of the non-communicable illnesses. When we look at the cost overall, if all the people quit tobacco and how much the country will save, the figures are definitely very impressive. And this is a report from Rijo John from the year 2021, which says that costs for counseling and successful quitting of all will be around 491 billion Indian rupees. And for the successful quitting, these will be 1,537 billion rupees. Comparing this, the country will potentially be saving 27.5 billion US dollars, which is 2,266 billion Indian rupee on account of tobacco-related illnesses and the death. The data, one more which will be helpful, is that India spends nearly 1% of GDP on managing tobacco-related illnesses, primarily three main tobacco-related illnesses. Those are cardiovascular, cancers, and respiratory diseases. So we have a huge burden, but this huge burden can be minimized by optimal utilization of the Quitlines. These are some of the questions which may arise naturally as how effective are Quitlines. And world over, the Quitlines have on an average quit rate of over 30%. Some of the proficient Quitlines have quit rates over 50%. Do the results differ for smokers versus smokeless tobacco users? The experience is from India, and largely from my experience, it does not differ at all. Neither the technology nor the results differ between these two types of tobacco users. Do these also provide cessation medicines? In some of the Western countries, these do provide nicotine replacement therapy to the callers or clients, as they call them, over 2 weekly supply basis and following it up. But in our country, the Quitlines do not provide any kind of medication. The fourth question is there a difference in the caller participation if these are offered at no cost? There is evidence that if the Quitlines provide the service at no fee, the participation of the users improve, or it is much more than if the Quitline is provided at a particular fee or a cost. So how much does it cost? Currently, for national Quitline, there is no cost. So we are fortunate. We are living in a country where the Quitline, calling on Quitline and getting registered and getting its service is free of cost. So I hope these are some of the questions which answers to these questions, which will help our participants to disseminate the information further. Now coming to the case study proper, and it started actually with my background of working for Quitlines in India, which I said we started way back in June 2008 when we wanted to establish a Quitline service for the Indian workplaces. And then we tried to make a technical transfer to Ministry of Health and Family Welfare when American Cancer Society was winding its operation sometime in December 2010, but it did not materialize. So thereafter, I had an opportunity to assist PSI India as its senior technical advisor to adapt this service further to serve 3 southern states, Tamil Nadu, Karnataka, and Kerala, for 2 years between 2011 to 2013. We had actually translated the script which we were using for the ACS Quitline into these languages. We trained the counselors, very proficient counselors, I would say. I had an opportunity to interact with and train them. But the Quitline could not sustain after 2 years due to the financial constraints, because it was running over the internal budgets, and then the states did not participate to support it further. So this PSI was simultaneously working at that time in Bihar and Rajasthan. And so in Rajasthan, being stationed at Jaipur, the capital city, where we have the state medical helpline, I volunteered to work for the state medical helpline to help them run the Quitline in an informal basis. Government could not really find out the potential, but the private partnership under this service, which is called as PAHEL, the private partner said that if there are no financial bearings, I will give you the platform, you come and train our counselors and help tobacco cessation in a better way. So sometimes the relations do work in a very helpful way and a constructive way to give back to the community what is required. The framework for counseling is not very different from what I would do in a tobacco cessation clinic. And therefore, through the script that we had planned and on which I have trained the counselors repeatedly, it includes working on rapport building, finding out the history for tobacco use, assessing their addiction level in a simpler way, getting the quit history from the past and knowing what works, what does not work, or what did not work and why did they relapse, and then giving them the knowledge and inputs on the harms of tobacco use, as well as emphasizing the benefits of quitting and staying tobacco free. And then those who are willing hereafter, we help them set up the quit date. And this is followed by counseling, which is primarily helping them for two things: for leading a tobacco-free life and also empowering them with the skills which they are likely to suffer, or as people suffer when they are quitting tobacco. We also forewarn them about the relapse prevention, relapse, and therefore what is required for the prevention, primarily the recall mechanism and staying away from tobacco, and then concluding the session by giving them the information about the follow-up sessions. So this is a brief information on the framework as to how the counseling is done through the Quitline. This Quitline in Rajasthan, which is still operational, although I haven't been able to be its part after 2019 post-COVID. It is based in our State Medical and Health Welfare Institute, SIFU, and it can be accessed to the toll-free number statewide through the number 104 and 108. It operates all 365 days from 7 a.m. to 9 p.m. The counselors communicate largely in Hindi, and it serves proactively to the initial intensive counseling session, followed by at least 5 calls to be made in next 12 months, that is on 3rd day and 7th day of quitting, and then at the end of 1 month, 3 months, 6 months, and then at the end of 1 year. So 6 calls, not 5 calls. And it also serves for alcohol de-addiction and also helping for other medical ailments and ambulance service. So this is additional help that the service provides, but we have the counselors who are able to provide Quitline service as a state of art here. What have been the challenges to the implementation? It is primarily at the state government level, its inability to create a post of consultant. But yes, I said, okay, if this cannot be done, I will work voluntarily for the people of the state. The Ministry of Health has not been able to realize the value the state medical helplines can add to the national Quitline in view of the availability of the infrastructure and human resource, and almost at no cost, because these are already available in the state medical helpline. This is one point that I really want to take back home. What are the challenges in its delivery locally? We have had the change in the private partners under public-private scheme of the government. Currently, we have the 3rd partner whom I haven't met, but the earlier two partners have been very encouraging and have been welcoming to help their service for enabling them to deliver tobacco cessation. There is an issue of attrition of the counselors, which sometimes happens very rapidly, and therefore they require repetitive trainings for their groups with varied experience. Somebody has joined in just a few days back, and somebody has been there for a year. So yes, it's a question of how do we assimilate and help them with the group working and the seniors helping the juniors. So yes, it's been a good experience. I would say it's not exactly the challenge. It's an opportunity also to work with the youngsters who are very keen to work as counselors and also enhance their value addition as for helping the people to quit tobacco. Also, yes, there has been a challenge of my inability to be on the site on a regular basis. Sometimes, although I have been visiting the service on a fortnightly basis, but we also have the counselors issues due to the offs and leaves, etc. That sometimes when you're doing the training, few of them are not available. Then, most importantly, the challenge which I found is deficient promotion of Quitline facility by the State Tobacco Cell, the National Health Mission, and the IEC specifically, that this service is available. Otherwise, many more could have perhaps utilized this service in the interim. Still, we have been able to get manage about 4,500 callers in 3 phases due to transition in the private partnership and the shift in the workplaces. In the latest cohort of it's 1,280 patients. Among the majority, these were male callers in the second and third decade of life, unlike the attendees of the tobacco cessation clinic. And a large number of them were found to be addicted to nicotine. And addiction we determine by how many times they are using tobacco, how soon they use tobacco after waking up, and whether they get the side effects or withdrawal symptoms on abstinence, and do they use tobacco even when they are sick. On that basis, we found that 82% were addicted to nicotine, which is much higher than the national averages and what we have through the gets to for Rajasthan as well, which is about 60%. It recorded a self-reported quit rate of 20%. 5% are those who had quitted within 1 month when we did the last assessment. 56% are those who had who failed to respond after their initial induction, and 19% were those who had failed. But we combine these together as one category as failure to quit. So we can see that about 20% had quitted for over a year, which is a pretty good number as compared to the outcomes that I know of tobacco cessation clinics informally in Rajasthan, which is about 5% quit rate. And we have had pretty good success, because it appears that those who quit successfully for a year, even at the end of 4 years and 5 months, 4.5 years, the quit rate has stayed at 17%, which in a way matches with my another series from tobacco cessation clinic, where I have a quit rate of nearly 36% at the end of 5 years. So one can also know that the Quitlines, when these are informally run, can give a quit rate of about 20%, versus the tobacco cessation clinics, where there is one-to-one physical touch, and there the quit rates are definitely almost double of what you're getting to the Quitline. But national Quitline does have a quit rate of 38%. So I believe, yes, we can do better even at the state medical helpline. Also, it is important to note that the counselors are not the psychologists or the counselors by the qualification. These are the students, these are the general nursing students, or those who have done the GNM course, or those who have done their courses, bachelor's degree in the social work, or sometimes they come for the working with the adolescent groups. So this is a varied group where the qualification and the aptitude at the initial stages is not as high as those who are as compared to those who are recruited as counselors for the National Quitline Service and its regional subsidiaries. So, in the continuing with the results, it also endorsed an evidence from my another study that at least 3 follow-up calls are essential for the quit rate of 20%. It also suggested that the duration of primary intervention and intensive intervention of 14 to 16 minutes suffices for an optimal outcome. And this I can also substantiate through my experience working for the tobacco cessation clinic in the hospital locally here during the times of COVID and thereafter, that yes, a call of 14 to 16 minutes suffices in most of the cases. So we can reduce the time of intensive counseling. And that also is the evidence obtained from the Cochrane analysis recently that what is most important is to have the counseling done for as little more than brief counseling for about 15 to 20 minutes. And it can also be more useful if it reinforces what is given as a brief counseling session to the patients who are attending the hospital or a TCC. So this is very valuable component evidence that I have found that yes, substantiating the other modalities of tobacco cessation delivery through the Quitline can give us the higher quit rates. What have been the lessons learned? The service, despite its informal status and voluntary support, has sustained till date. It is now close to over 12 years. It appears feasible to establish a Quitline formally within a setup of state medical helpline at no cost. I think that's a point that we need to understand and accept. The need is the adequacy of the resources and sustained support by the center and state agencies for running these services optimally. What is this translatory value? The benefit to the common people as a result of the intervention. Through the higher participation of the tobacco users and their communities, this model can provide an increase in the quit rates that are currently prevailing, reducing tobacco burden and resultant disease and deaths, which are over 15 lakh annually. I think this is something which can be very useful. So to conclude, the sustained quit rate of 20% through the different sets of counselors in 3 different cohorts and under 2 different private partners can be considered as the most significant outcome of this case study. And hence I recommend integration of Quitline in a state medical helpline. It's a definite feasibility. And since the state-of-art Quitline services could be delivered through the state medical helpline in Rajasthan, a countrywide application can help national and regional Quitlines to overcome their current challenges of inability to serve optimally in view of deficient human resource and the infrastructure. I thank you very much for your kind attention, and I stop here and will be very happy to answer any questions you may have.
So thank you, Dr. Rakesh Gupta. So you have very nicely told about the types of the Quitline. They can be reactive, proactive. Then you also told about the advantages of the Quitlines, that you can maintain confidentiality and they are flexi hours. And no visits are required to the TCC. And the database you get, you get very good database. And it is also heartening to know that India is amongst the 26 countries which have CCCs, we have national Quitlines, we have M cessation. So, and you have a very good experience with your own state Quitline, and that is very heartening that almost 12 years you have spent on this. You have already spent 12 years using this medical helpline, like providing services to the people. And the thing is that there's very fast attrition of counselors. That I think that is the main problem, and you have to teach them time and again how to do counseling. So now I'll request, we have Dr. Aruna, she's a very senior dentist with us. And then we have Dr. Dilip Acharya, we have Binay Matthew. And so I'll just ask for their comments before I ask our chief guest to give his final comments.
Yeah,
Dr.
thanks a
Aruna,
lot.
please.
Yeah, thanks a lot, sir. So thanks a lot.
Very brief
Yeah,
comments. Yeah, no
valuable
problem.
inputs on the toll-free National Tobacco Quitline services, as well as the one of the models set by the Rajasthan Cancer Foundation related to the Quitline, sir. Sir, actually, I have one query, sir. Like, if at all the client reports of any of the comorbidity, be it psychiatric or else the physical comorbidity, do they connect to the next Quitlines, toll-free Quitlines?
In this state medical helpline is primarily meant to respond to the medical emergencies of the people and give them the guidance as to where they can go for their primary element. So yes, it does help. In a way, it's good to have a state medical helpline. Although I'm saying that I consider having a specific quitline to quit tobacco can definitely have better results for quitting tobacco. But a mix of state medical helpline giving the assistance to the people to help with other comorbidities, I think is definitely a virtuosity of helpline or a quitline. Have I answered?
Thank you, Dr. Aruna. And may I ask Dr. Dilip if he has some comments to make?
Not to the comment, but appreciation. I know Dr. Rakesh has been associated for this, that he started the Quitline way back and with ACS also. And we thought that we'll be able to follow him up in Madhya Pradesh. But unfortunately, Madhya Pradesh could not just start it. But I'm sure that with the national law coming up now, and with the good results coming up with the 38% quit rate, the others local languages should also follow it up much better way. So it will be a good thing. My best wishes always are there with you. Thank you.
Thank you, Dr. Dilipji. We are in better times.
May I ask Mr. Binoy? Mr. Binoy, if you have some comments to make, please.
I'd like to thank Dr. Rakesh, sir, for giving a wonderful presentation. And it's always learning for us to hear from him, because as he's an expert in the tobacco cessation thing. I just have one comment, and I just talked like from the communication point of view, sir. Sir, there has been a lot of work that has happened on tobacco cessation, and also you talked about the Rajasthan as a example. But what I see from the media point of view and an article also, sir, much of this has not been reported much on the tobacco cessation. Yes, of course, in the GATS report, what we have seen that, cessation, the quitline was also one of the medium for the, for the prevalence thing. But yes, we need to basically highlight more and more people, like, in the urban city, many of them are aware about this quitline, but, going to the rural areas, and many of them, we need to, from the communication channel point of view, we need to, spread this in a very effective way. And, more needs to be reported, like, as compared to other issues that are going on, tobacco control issues coming up in the media. But this is also one of the area that needs to be addressed, effectively. That's my comment, sir. Thank you.
Thank you, Binoy. I think you have made the point very clearly. I could not do it, the media advocacy, which I generally do for other tobacco control issues, because here I was working as a volunteer, and approaching the media here will require the permission from both the partners, the private partner and the government partner, which wasn't easy to come by. So honestly, I did not even attempt that. But yes, we have been trying to disseminate the information through our tobacco control partners, and through the Dr. Sonu has given now an opportunity where we have made a case study. So I hope it gets the due recognition and is utilized optimally accordingly. Thanks indeed.
So, Dr. Rakesh, I think we have Dr. Vikrant with us.
Yes.
Dr. Vikrant, are you still with us, sir? Dr. Vikrant, maybe he has left. Ms. Avdeshji is with us. If he can give some comments on the presentation and how he can follow in his own state. So I think he is also not there. So then there is Avdeshji, are you with us, sir?
Yes, sir. Yes, sir. Thank you, sir. It was a very good presentation, sir. And I was not aware about the cost of Quitline and percentage of any research report, how many people quitting. So it is very good presentation, sir.
Thank you. Thank you. I did not mention here that I did work with Dr. Gopal Chauhan, and we did empower the counselors working with the Himachal Pradesh State Medical Helpline. Somehow it could not really go beyond the training part because of the financial constraints which the state expressed, and could not really help the callers there for quitting tobacco.
So Dr. Rakesh, we'll just take two more questions.
Yes.
So what is the definition of quitting? Actually, Mr. Arunjit Singh has asked about the question. What is the definition of quitting?
If a person quits successfully, that means he has stayed quit for all types of tobacco for at least a month or more. And so this is what is required. And then our definition for a successful quit is that somebody doesn't use the tobacco at all thereafter. Some slips do happen sometimes, but we do not accept the relapse, which is primarily starting to use tobacco again. It does happen. In my tobacco cessation clinics report or cohort that I have over 1,000 patients, the relapse rate over 5 years is 19%. So yes, people do relapse after successful quitting. They do require support, and people do appreciate the support. So telephonic follow-up is a must for whether you are using Quitline service or you are delivering it to the tobacco cessation clinic.
Actually, I can't access the chat. If anybody has a quick question, just one more.
Yes, so there's a question by Siddhi how to start and manage these helplines? What different types of manpower will be needed?
Yeah, just the last question. Yeah, thank you.
I think in any helpline, and the counselors who are there, who are the counselors for everything, they can be trained for
please keep yourself muted if you're not speaking. Thank you.
Yeah, so I think if you can get the access to the counselors in state medical helpline, and their participation is encouraged every time the master trainer is going to view their database as well as listen to their recordings. And this is what I did exactly. I mean, I used to go every time. The supervisor there used to give me 4 or 5 recordings of these counselors. We used to listen it together, tell the counselors as to where they did very good, what helped the caller the most, and where they could have improved. So this is how these interactive sessions help to prepare the counselors, regardless of their background, for delivering the Quitline services. But naturally, where the counselors are working in a specific Quitline service, they are much more trained, they are engaged on a regular basis, and for delivering these only to the tobacco users, the quit rates are definitely higher in those Quitlines versus such informal helplines or informal Quitlines.
So, Dr. Sanchika, I think we can't take any more questions, but anyone who has any query, they can just send query to Sipher2018@gmail.com, and we'll try to answer the questions after asking Dr. Rakesh Gupta. And before asking our chief guest, Maj.General Professor Atul Kotwal, for his final comments, I'll request all of you to please switch on your videos for snapshots to be taken by Dr. Sanchika. So, Maj.General Kotwal, so I'll request you to please give your concluding remarks. Sir, you're muted, sir. Sir, you're muted.
Okay. Thank you, Dr. Rakesh, and thank you, Dr. Rakesh Gupta. I must commend you and congratulate you for this excellent talk. Very crisp, very informative, and also commend you for the excellent work which you have done. That is, I think, very more important, because the talk also, it was clearly visible that you are passionate about it and you have worked on ground in it, rather than just presenting it from the knowledge sake, as said, from that point of view. So that is really commendable. And
Thank you.
I'll just like to share something here that, under the newer expanded packages now at health and wellness centers, MNS package is being rolled out. That's mental, neurological, and substance abuse issues. And the trainings have been done for the CHOs, for the ANMs, for medical officers, for staff nurses, to make these services available to the community as such. Yes, implementation, as we all know, is always a challenge. It is taking time to get the expanded packages implemented. The numbers, I think that's what we need to. I think we need to have a relook at the 102 and 104 which you shared. Technically, in all states, 102 and 108 are for the patient transport vehicles or ambulances, and 104 is the grievance redressal system. So that's where we need to have a probably different number. But I think I'll go beyond that. Telemanas initiative was launched last year, and NHSRC and NIMHANS and IIITB Bangalore, we three, got down together, and we formulated the guidelines. 51 nodes have to come up all over the country. Rajasthan has been allocated 2 nodes. Rajasthan has made one functional, not made another one functional. And out of the total nodes, 43 are fully functional, and more than 2.86 lakh calls have already been received by the Telemanas cells till date. And a few of the states have also, listed the number of suicide cases which they could prevent after subsequent to a call. And a large proportion of these are also related to the substance use and misuse or substance abuse. So I think it's time to integrate and probably get the Quitlines because the tobacco use and tobacco abuse and all the substance abuse is part of the Telemanas helpline. So we need to look at, if there's a capacity building required for the counselors at the Telemanas sites, because it's a very well designed, initiative with appropriate funding available for next 5 years, which is dedicated funding available. And there are cells, big cells of 20 people, small cells in smaller states of 10 people, and a linkage with the regional centers and the mentoring institutions. And we started having clinical meetings also where cases are also started being presented now. So that's the kind of involvement everyone has, and the regular, weekly review meetings and monthly review meetings where all of us get involved. And the dedicated team looking after Telemanas in NHSRC as well as Ministry of Health and Family Welfare. So and plus of IIITB and NIMHANS Bangalore and 23 other centers all over the country. So it is time we try to leverage that so that this gets upscaled immediately. And I think that on that we will have a discussion with you on sidelines, and Dr. Sonu Goyal and we include 2-3 more people on I think 12th. So yeah, I'm having a meeting in Niti Aayog. We're going to discuss the National Mental Health Program, and Telemanas is a part of that. So before that, we need to sit down and jot down a few points that what is should approach should be taken, how to understand the replicate this excellent practice and rather upscale it immediately for the entire country rather than looking at state-wise as such. And the platform is already available. Yes. So, but great. Once again, thank you very much for sharing this and for the success which you have achieved with this. And, in tobacco control, as we all know, the more we do right now, it is less. So we all need to, work together to ensure that we make people quit, and rather it's time should come that people should not start. That's the the ultimate aim we all should have. But once again, thank you very much to the organizers and to you for excellent talk and for the passion and your commitment which you have for the tobacco control. Thank you very much.
Thank you very much.
Thanks a lot, sir, for your brief comments. And I'm sure that the message will reach the authorities, and maybe they think about adopting this helpline, the Rajasthan helpline.
He has given us an action item already, Dr. We need to follow up with him before the meeting on 12th, his meeting with Niti Aayog. So
yeah, Dr. Sonu Goyal is with us, so I think he'll surely follow up with sir. And sir, I'd like to acknowledge the presence of Dr. Ramprasad, Dr. Siddhi, Dr. Sahana, and Dr. Siddhi Hathiwala. And there are many more. I may not be able to look at them actually. I'm thankful to all. And I'll request Dr. Sanchika to please invite Dr. Rajiv, Mr. Rajiv.
Thank you, sir.
For the vote of thanks.
Now I would request Mr. Rajiv Chaudhary from RCTC for the proposed vote of thanks.
Rajiv, are you with us, sir? So Arunji, you can do the honors then. Please unmute yourself. Arunji, please unmute yourself.
Thank you, Dr. Rakesh and Dr. Sanchika. It was indeed a very crystal clear and a very crisp presentation. I mean, any layman could have understood it, whosoever not been in this line for so far. And we are, I'm doing this duty. It's an honor to do this duty of proposing a vote of thanks to our chief guest, Major-General Dr. Prof.Atul Kotwal, Executive Director. Sir, we are really extremely grateful to you for sparing some time out of your very, very busy schedule, as Dr. Sonu told that you have some projects, some in line, some programs in line in the next 2 days. Thank you so much, sir, for being with us. I thank Dr. Rakesh Gupta, who has been the presenter and our resource person today, who has made a very, very, excellent presentation. Thank you, Dr. Sir. Thank you so much. I also thank all our participants and the eminent participants and public health students and all the doctors who have been part of this webinar and who have spared the time to, because I could see at one time we were almost 64, 65 participant. I thank Dr. Rakesh Gupta, whose efforts are always there to organize such webinars, and indeed Dr. Sanchika as well as ECO India, who are helping us to supporting us to organize these programs. I thank Dr. Sonu, Mr. Rajiv Chaudhary, Program Coordinator, and all our participants. Thanks once again and good day.
Thank you.
Thank you, sir. Now we take one more.
Namaskar. Thank you. Thank you all.
Thank you, sir. Thanks a lot.
Yeah. Yes, Sanchika, you wanted to say something.
Yes, sir. Just 1 more minute I would take from the audience. Our next session is on next Wednesday, 13th of September. Our topic for that day is setting up a tobacco cessation clinic in private hospital, and our speaker will be Dr. Rakesh Gupta from Rajasthan Cancer Foundation. So, sir will be speaking, will be with us next week also. Please do join us at 4 o'clock next week. Thank you for joining us today. Namaste.
Thank you. Namaskar.
Thank you so much. Best wishes. Thank you so much.
Thank you.